First of all, I would like to thank the Diabetes India organizer for inviting me. Thank you very much. I'm Dr. Kalpana from Diabetes Unit KEM Hospital Research Center Pune, and my topic of presentation is early diagnosis of Wolfram syndrome, masquerading as type 1 diabetes with complication. It's based on my clinical experience as a practicing pediatrician as well as working in diabetes for last many years. Before I proceed, I would like to have a quick look in the history. It was just two major milestones. It was in 1938, Dr. Wolfram and Dr. Wegener from Mayo Clinic presented four siblings having early onset insulin-dependent diabetes along with bilateral optic atrophy. This association was named as a Wolfram syndrome. Later on, many new features were added to that, including by Dr. Wegener also. But the thing is, pathophysiology wasn't very clear till in 1998, a Japanese scientist named Dr. Inouye, who located the gene responsible for this Wolfram syndrome on short arm of chromosome 4, and we call it as a WFS gene, wolframin gene, which encodes the wolframin protein. And gene identification resulted into genotype-phenotype correlation and broadened the Wolfram syndrome into a spectrum disorder. I'm going to focus on a classical Wolfram syndrome, which is also called as a DID mode. Recently, U has been added to that, indicating that urinary tract dysfunction can be a major criteria. Now, as you all know, it is autosomal recessive neurodegenerative disorder, progressive in nature, and involves multisystem also. It's characterized by 5 major diagnostic criteria, and there are other additional neurological and endocrine criteria which are considered as a minor criteria. I'm not going to read this. Anyway, the most important thing is these features evolve over a long time, and the order of emergence is also very unpredictable. So what I mean by order of emergence is unpredictable is, see, you can develop diabetes insipidus before optic atrophy, or why one can develop deafness before also diabetes also. So the thing is, clinical diagnosis of Wolfram syndrome must be considered when a patient, for us, is going to be a diabetic, presents with any two or more of these major clinical criteria. Now the thing is, clinical criteria well defined, then there is a genetic diagnosis available. It's possible to diagnose Wolfram syndrome at early stage, because early diagnosis will definitely improve the quality of life, and second thing is it may delay the complication also. But delay and mixed diagnosis is often there, and which is reflected in various publications, international, national publication, as well as in case reports. Here are few titles, very few titles I have illustrated here. The thing is, there are many reasons for this. I mean, there are valid reasons for this misdiagnosis and delay. There was a Mexican study which caught my attention because the author emphatically attributed this to the insufficient clinical vigilance among the healthcare providers. Okay, so we at our center, which is a tertiary diabetes referral center, Pune, decided to scrutinize our diabetes record for two things. Is there an misdiagnosis? And two, whether early diagnosis of Wolfram syndrome was possible in our already diagnosed cases. Now, this is our registry. We selected the regular follow-up patient. Why regular follow-up patient? Because Wolfram syndrome has got a timeline, and a disease record was selected. And what we did the retrospective analysis of clinical and investigational profile of every record to check for anomaly, including eyes, hearing, urological or neurological problem, or for that matter, any other problem, and give special attention to that. So what we noticed? So from the regular follow-up patient, we have 12 patients, but they were genetically confirmed, no new case. From the disease record, we had 2 patients, had clinical confirmation, one had a genetic confirmation also, but there were 3 patients from the disease record who were mislabeled as having type 1 diabetes with early complication, and unfortunately they succumbed at very young age. And when we started checking their clinical record, the history was spanned across a period of say 12 to 18 years. They were seen by multiple observers. They had many symptoms. Either these symptoms were attributed to as a diabetes complication, or it was thought that it is unrelated to diabetes and referred to the specialty. Well, when we start, it was just like, collecting the jigsaw pieces and putting them together. And the diagnosis look very simple, but then we all know that we are all blessed with a hindsight of 2020. So leave it apart. I mean, the thing is, we are going to locate their DNA from our biobank and soon hope to get their molecular diagnosis. So we did miss 3 patients. Now the part 2, whether early diagnosis of Wolfram syndrome was possible. And for that, we selected our 13 genetically confirmed patient. First thing we decided, what is the diagnostic delay like? What I mean by diagnostic delay is the time required to change the title from type 1 diabetes to clinically recognized Wolfram syndrome. And this slide shows the distribution. The thing is, average delay was 13 years, median delay was 8 years, but let me tell you that for a record, the maximum delay was 28 years. So the next question is, can we shorten the delay? The thing is, yes, the answer is very simple, that be vigilant and look out for early clinical features. But was that very simple? Anyway, we'll see that. Now, this is the phenotypic characteristic of these 13 patients, showing the major phenotype characteristic. Now you can see here that now 10 out of 13 patients have exhibited full-blown Wolfram syndrome. But the thing is, our primary interest was in checking for the early diagnostic clues. So what we did, the thing is, we reviewed the clinical notes from the time of diagnosis of diabetes to first few years, just less than a decade. Let me tell you that, just that less than a decade. And if needed, we interviewed this patient to update the history also, because they were from a regular patient. So did we find any clues? Okay, let's begin. The first manifestation is diabetes. So all our index cases presented in diabetic ketoacidosis. Second thing was, two of our patients were antibody titer positive, and rest of the diabetes parameters were consistent with type 1 diabetes. There was no clue at all from the diabetes. Now the second thing is, well, majority of our patients reached their diagnosis after optic atrophy was declared by the ophthalmologist. And obviously optic atrophy is a late finding. So something was evolving, probably which we missed. So what was that? When we referred the clinical notes, we noticed that these kids have impaired vision, poor vision, and this impaired visual acuity was attributed to refractory error, even if the best corrected vision was never satisfactory for any child, or it was considered as it's a diabetes complication. Okay, now the second thing is, color vision was never checked. And the third thing is, annual ophthalm checkup used to be focused on the presence or absence of diabetic retinopathy. So here was our first clue, that checking for a visual acuity and checking for the color vision. Now there were three patients. The thing is, the notes mentioned that they had impaired hearing, and later on there is no further elaboration because they were referred to the ENT or some specialty, and actually two of the patients were referred by the school authorities. Well, there is no further information, but then history update showed that two of these kids are using hearing aids, and the third left the school because the child can't hear it. So the second clue was checking for hearing, was our second clue. Now the third thing, as you all know, phimosis and urinary tract infection is quite common. Like, it's not very uncommon in type 1 diabetes. I mean, you can come across that. But the thing is, accompanying hydronephrosis is distinctly rare in such condition. So here were two patients and they had symptomatic phimosis. And when pre-surgery sonography was done, it showed mild to moderate degree of hydronephrosis. Now, retrospectively, we think that the urinary tract atony was at that time only, which was precipitated because of the anatomical obstruction, or there was a urinary tract infection causing a functional obstruction, and which resulted into precipitation of the urinary tract atony. Maybe at that time there was partial DI also. Anyway, so this became our next feature, that checking for hydronephrosis, and most thing is not ignoring that hydronephrosis. Keep it in mind that there is a hydronephrosis. Then another symptom is a shared symptom between Wolfram syndrome and diabetes. We all know polydipsia, polyuria, enuresis, nocturnal enuresis. Now here are two kids. They had enuresis from a very, beyond their childhood period. They were investigated. Let me tell you that one patient was investigated for osmolality testing also, but that turned out to be normal because maybe at that time there was a partial DI. Now the next summary is just a pictorial representation. And the thing is, when we check the urine report, it provided us a clue. Now at one glance, you will say that there is a glucoseuria. But when you ask you to focus on this report, you will see, and mind you, this is a fasting sample. The thing is, for +2 glucose, the specific gravity is 1005. And for comparison, I have put another report, identical, 2 plus, but the specific gravity is 1025. So what is specific gravity? Specific gravity in simple word is the weight of the urine. If glucoseuria is going to come, obviously the weight has to increase. And whenever there are many diabetes, too many diabetes, let us say like that, that diabetes mellitus in diabetes insipidus, checking specific gravity has got diagnostic significance. And in fact, let me tell you that those patients who were later diagnosed as having DI, for an extended period of time, they had a low specific urine gravity which went unnoticed. So this was our next clue. And when we asked for the volume of the urine, this patient shared just this picture. This 10-liter bottle gets filled by urine within 24 hours. So another is measuring the volume also. So this was our next clue. Now this is a summary of our early diagnostic clues. You can see that for a one, multiple clues were there, a clinical clues, and that too in a short period of time. I just said before 1 decade we checked it. Second thing is the order of emergence you can check is unpredictable. As I mentioned, that order of emergence of clinical feature is unpredictable here also. So if these early diagnostic features are recognized and then they are further investigated, they should become our early phenotypic characteristic of our Wolfram syndrome. Now, based on this, we devised a very simple screening protocol. We just hung a Snellen chart for checking visual acuity, use Ishara chart for checking the color vision. There are even mobile apps are there where self-testing can be done. And actually, it was Dr. Wagner who used to use his ticking watch to check for the subnormal hearing. The second hand of a wristwatch produces a high frequency sound, and that's the method we used it. Urine routine was either checked in the lab or the help of the reagent strips. Besides focusing on the biochemical analysis, we focused on the specific gravity also. A fasting urine was preferred. A fasting urine of less than specific gravity showing 10-10 was repeated, noted, followed, and further investigated. If there is any biochemical analysis, we went ahead with the checking for hydronephrosis and focusing on that also. Last is adding insulin smell was an afterthought because it's very easy to do. As you all know, insulin has got a very characteristic, unmistakable smell, and all our kids are familiar to that smell. And if they can't identify that smell, this is definitely pathognomic. So we started applying this protocol. One thing I forgot to mention that out of this 13 patients, 3 patients were having short stature, and which was they were investigated for celiac disease, as well as other endocrine problems also. So our short stature became a red signal. We started applying this protocol in our OPD form 2023. And let me tell you that my diabetes team identified 5 patients who were previously labeled as having type 1 diabetes. At the time of screening, they had multiple features. Here you can see that out of 5, 4 patients had impaired visual acuity, color vision was impaired, specific gravity was less than 10-10 for all the patients. One patient had suboptimal smell sensation, 3 had subnormal hearing. So here you can see that multiple features are there. 2 patient UTI followed by hydronephrosis. I want to focus on the last patient only. This is a male child, 4-year child, and then he developed diabetes at the age of 4 years, had symptomatic phimosis at the age of 5 years. As per the protocol, we did the sonography and we showed mild to moderate degree of hydronephrosis. Specific gravity was suggestive of diabetes insipidus. Now that this patient had color vision was normal on Ishihara chart, but then one of my distinguished ophthalmologist friends suggested me that if I want to check the color vision, early color vision will not be checked on a Ishihara stars. What I want to use is a Hardy-Rand Rittler chart, and not many people were aware of that. Anyway, even getting that chart available is also very difficult, but we procured that chart and we found that the child had blue-yellow color blindness. And this is a list diagnostic delay. I'll show you that is within a year he has been diagnosed as a Wolfram syndrome. And let me tell you that all these 5 patients targeted, they were confirmed genetically. So let me conclude that Wolfram syndrome may be more common in type 1 diabetes clinic than previously thought. Various studies mention its occurrence as 0.57 to 5.5%. Though optic atrophy in juvenile diabetes is the diagnostic feature, early or soft signs suggestive of its characteristic can appear way before a noticeable optic atrophy. And I think in the world of AI and technology, our simple clinic-based protocol definitely increase the vigilance, enabling, I call this model as a retro model in this today's world, and which increase our clinical vigilance, enabling early diagnosis of Wolfram syndrome, and that can be confirmed by molecular testing. So for me, I always say that Wolfram syndrome's analogy is like a wolf in a sheep's clothing, and for the namesake, we'll say wolf in a ram's clothing, okay? And don't miss the obvious one, and definitely be vigilant for that which is not very obvious. So I think before I conclude, I want to thank my diabetes team, particularly Dr. Yadnik sir, then my colleagues, and basically my educator and nutritionist team. Without their help, it was impossible to collect this data. And anyway, thank you very much for your time and attention. Only